This video on heart failure with reduced ejection fraction is for educational purposes only. Let's dive in. Heart failure with reduced ejection fraction is defined by an ejection fraction of 40% or less. It accounts for 40 to 50% of heart failure cases with ischemic heart disease as a leading cause. Prevalence increases with age, affecting men more, but outcomes are worse in women. High hospitalization and mortality rates are noted, with survival rates comparable to malignancies. Heart failure most commonly results from ischemic heart disease, followed by long-standing hypertension that leads to dilated cardiomyopathy, valvular heart disease affecting the aortic or mitral valves, and primary dilated cardiomyopathy that may be idiopathic or familial. Other important causes include myocarditis, toxic exposures such as alcohol and certain chemotherapy agents, persistent arrhythmias including atrial fibrillation or sustained tachycardia, and metabolic or systemic disorders such as diabetes mellitus, thyroid disease, hemochromatosis, amyloidosis, sarcoidosis, and micronutrient deficiencies. Heart failure is driven by reduced cardiac contractility leading to lower stroke volume and cardiac output, which triggers compensatory neurohormonal activation of the renin-angiotensin-aldosterone system and the sympathetic nervous system. These responses cause sodium and water retention, increased venous pressure and congestion, while chronically promoting adverse ventricular remodeling with myocyte hypertrophy and fibrosis. Over time, these changes lead to serious complications, including malignant arrhythmias and sudden cardiac death, thromboembolic events such as ventricular thrombus and stroke, pulmonary edema with secondary pulmonary hypertension progressing to right heart failure, progressive worsening of systolic function, and end organ damage involving the kidneys and liver. Clinical presentation of HFrEF includes symptoms like dyspnea, fatigue, and edema. Signs include elevated jugular pressure and pulmonary crackles. The NYHA classification ranges from no limitation to symptoms at rest. The ACC-AHA stages range from at risk to end-stage heart failure, guiding treatment and management strategies. Evaluation of heart failure relies on laboratory testing and electrocardiogram assessment to establish diagnosis, determine severity, and guide therapy. Brain natriuretic peptide levels below 100 picograms per milliliter makes heart failure unlikely. Levels between 100 and 400 is indeterminate, and levels above 400 strongly supports the diagnosis. N-terminal pro-brain natriuretic peptide levels below 125 picograms per milliliter suggest heart failure is unlikely, and levels above 1,000 indicate more advanced disease and worse prognosis. Electrolyte abnormalities such as low serum sodium are associated with poor outcomes, and abnormal potassium levels may occur due to diuretic or renin-angiotensin-aldosterone system therapies. Kidney function tests often show elevated urea and creatinine from reduced perfusion or congestion, and liver enzymes and bilirubin may rise due to congestive liver injury. Thyroid and glucose testing assess reversible or contributing conditions. EKG commonly shows sinus tachycardia, atrial fibrillation, prolonged ventricular conduction, especially with left bundle branch block, pathologic Q waves indicating prior myocardial infarction, and ST segment and T wave abnormalities, while ventricular arrhythmias increase the risk of sudden cardiac death, and a wide conduction pattern with ejection fraction at or below 35%, and persistent symptoms identifies patients who may benefit from cardiac resynchronization therapy. Chest X-rays in heart failure show cardiomegaly and pulmonary congestion. Echocardiography in heart failure with reduced ejection fraction typically demonstrates a reduced left ventricular ejection fraction of 40% or less with global or regional impairment of left ventricular contraction, often accompanied by left ventricular dilation and thinning of the ventricular walls. Echocardiography in heart failure with reduced ejection fraction shows a reduced left ventricular ejection fraction of 40% or less. It shows a dilated left ventricle and global systolic dysfunction. Often, there are regional wall motion abnormalities suggesting ischemic disease. Functional mitral regurgitation can occur due to ventricular dilation. Elevated pulmonary pressures may indicate possible right ventricular dysfunction. In severe cases, there may be the presence of a left ventricular thrombus. Guideline-directed medical therapy for heart failure with reduced ejection fraction includes 4 pillars: a beta-adrenergic receptor blocker, renin-angiotensin system inhibitors, or angiotensin receptor neprilysin inhibitor, a mineralocorticoid receptor antagonist, and a sodium glucose cotransporter 2 inhibitor. These therapies aim to improve survival and quality of life by managing symptoms and reducing hospitalizations. Treatment is tailored to individual patient needs and clinical presentations. Beta-adrenergic receptor blockers are a cornerstone of treatment for heart failure with reduced ejection fraction and have been shown to reduce mortality and hospitalizations when specific evidence-based agents are used. Recommended medications include carvedilol, metoprolol succinate in extended release form, and bisoprolol, which work by counteracting chronic sympathetic nervous system activation, lowering heart rate, reducing abnormal heart rhythms and myocardial oxygen demand, and promoting reverse remodeling of the left ventricle. Therapy should be started at a low dose only when the patient is clinically stable and free of fluid overload, with gradual dose increases every 2 to 4 weeks, as mild early worsening of symptoms may occur and is usually transient. These medications should be avoided in acute decompensated heart failure, cardiogenic shock, severe slow heart rate, advanced conduction block without pacing support, or active bronchospasm. Among the available options, beta-1 selective agents such as metoprolol succinate and bisoprolol are preferred in patients with reactive airway disease because they have less effect on bronchial tone. Renin-angiotensin system inhibition is crucial in heart failure with reduced ejection fraction. ARNI, such as sacubitril/valsartan, is preferred, with ACE inhibitors and ARBs as alternatives. These agents reduce mortality, improve symptoms, and prevent adverse remodeling. They offer vasodilation and neurohormonal benefits, enhancing patient outcomes. ARNI, specifically sacubitril/valsartan, is indicated for chronic heart failure with reduced ejection fraction. Combined neprilysin inhibition and angiotensin receptor blockade with sacubitril and valsartan is indicated for patients with chronic and persistent symptoms despite standard therapy, and is recommended as a replacement for angiotensin-converting enzyme inhibitors or angiotensin receptor blockers to reduce mortality and hospital admissions. Sacubitril enhances endogenous natriuretic peptides by inhibiting their breakdown, leading to increased sodium excretion, diuresis, vasodilation, and reduced cardiac fibrosis and hypertrophy, while valsartan blocks the angiotensin II type 1 receptor, decreasing vasoconstriction, aldosterone release, and maladaptive ventricular remodeling. Through this dual mechanism, the therapy restores neurohormonal balance, improves cardiac function, alleviates symptoms, and provides significant long-term survival benefit in appropriately selected patients. ARNI dosing depends on prior therapy and blood pressure. Initial doses vary, with a target of 97/100 milligrams twice daily. Lower starting doses used in treatment-naive individuals, older patients, those with low blood pressure, or impaired renal function, and gradual titration to a target dose. A mandatory washout period of 36 hours is required after stopping an angiotensin-converting enzyme inhibitor before starting therapy to reduce the risk of angioedema. Adverse effects include hypotension, worsening kidney function, dizziness, and rarely angioedema. The medication is contraindicated in patients with a history of angioedema related to renin-angiotensin system blockers during pregnancy and severe liver disease. Mineralocorticoid receptor antagonists like spironolactone and eplerenone block aldosterone effects, reducing sodium retention and fibrosis. They are indicated in patients with persistently reduced left ventricular ejection fraction with persistent symptoms, despite RAAS inhibitors and beta blocker. They improve outcomes and limit remodeling. Monitoring of potassium and renal function is essential to prevent complications. Principal risks include elevated potassium levels and worsening renal function, while eplerenone may be preferred when hormonal side effects like gynecomastia occur with spironolactone. Sodium glucose cotransporter 2 inhibitors are a core therapy for heart failure with reduced ejection fraction, with dapagliflozin and empagliflozin given at a dose of 10 milligrams once daily and shown to reduce heart failure hospitalizations, improve quality of life, and improve survival regardless of diabetes status. These agents act through mild osmotic diuresis, improved myocardial energy utilization, and reduction of inflammation and fibrosis, with minimal effect on blood pressure and good overall tolerability, making early initiation desirable. Additional benefits include improvement in cardiac structure and function through reduced hypertrophy and enhanced diastolic performance. Common adverse effects include genital fungal infections, volume depletion, and low blood pressure, while rare cases of normal blood sugar diabetic ketoacidosis may occur. These medications should be avoided in patients with type 1 diabetes, active diabetic ketoacidosis, or severe kidney failure with an estimated glomerular filtration rate below 20 to 25 depending on the specific agent. Hydralazine combined with isosorbide dinitrate is an evidence-based vasodilator therapy used in selected patients with heart failure and reduced ejection fraction to improve symptoms and survival. Hydralazine reduces arterial resistance and afterload, while isosorbide dinitrate causes venous dilation and reduces preload, together increasing stroke volume and lowering cardiac workload. This therapy is particularly beneficial in African American patients with persistent moderate to severe symptoms despite optimal standard medical therapy, and in patients who cannot tolerate renin-angiotensin system inhibitors due to conditions such as angioedema, severe electrolyte disturbances, or advanced kidney disease. Benefits include reduced mortality, improved symptoms, and fewer hospital admissions, while limitations include headaches, dizziness, low blood pressure, reflex fast heart rate, rare drug-induced lupus, and challenges with adherence due to multiple daily dosing. Diuretics are used in heart failure with reduced ejection fraction to relieve symptoms of fluid overload. Loop diuretics, including furosemide, torsemide, and bumetanide, are the main agents. They do not provide survival benefit. Careful monitoring of kidney function and electrolytes is required, and in cases of inadequate response, combination therapy with a thiazide-type diuretic may be used to overcome resistance. Anticoagulation is indicated in patients with heart failure and coexisting atrial fibrillation based on stroke risk, in those with left ventricular thrombus or prior systemic embolism, and in patients with mechanical heart valves. Anticoagulation is not routinely recommended in patients who remain in normal rhythm without these conditions. Direct oral anticoagulants are generally preferred when appropriate, while vitamin K antagonists are required in patients with mechanical valves or significant mitral valve disease. After optimization of standard medical therapy in heart failure with reduced ejection fraction, additional pharmacologic agents may be considered in selected patients to improve symptoms and reduce clinical events. Ivabradine is indicated for patients in normal rhythm with a resting heart rate of 70 beats per minute or higher, despite maximally tolerated beta-adrenergic receptor blocker therapy, and is used to reduce heart failure hospitalizations. Vericiguat may be added in patients with recent worsening heart failure or recurrent decompensation to improve outcomes by enhancing cyclic guanosine monophosphate signaling. Digoxin can be used to improve symptoms and reduce hospital admissions in patients who remain symptomatic despite optimal therapy, particularly when additional heart rate control is needed. Polyunsaturated fatty acids may provide modest benefit in symptomatic patients, while potassium-binding agents are useful for managing elevated potassium levels and allowing continuation of life-saving therapies. Calcium channel blockers that reduce heart muscle contractility should be avoided because they worsen systolic function, whereas dihydropyridine agents have a neutral effect and may be used only when required for hypertension or angina without improving survival or cardiac remodeling. An implantable cardioverter defibrillator is used in selected patients with heart failure and reduced ejection fraction to prevent sudden cardiac death, but does not improve symptoms. It is indicated for primary prevention in patients with persistent left ventricular ejection fraction of 35% or less, despite at least 3 months of optimized medical therapy, with mild to moderate symptoms and an expected survival greater than 1 year, as well as in patients with ischemic cardiomyopathy who are asymptomatic but have a left ventricular ejection fraction of 30% or less at least 40 days after myocardial infarction. For secondary prevention, the device is indicated in patients who have survived cardiac arrest or experienced sustained life-threatening ventricular arrhythmias not due to a reversible cause. Cardiac resynchronization therapy is used in selected patients with heart failure and reduced ejection fraction to improve symptoms, reduce hospitalizations, and lower mortality by restoring coordinated contraction of the ventricles. It is indicated in patients with a left ventricular ejection fraction of 35% or less, normal sinus rhythm, left bundle branch block pattern, QRS duration of 150 milliseconds or greater, and persistent moderate to severe symptoms despite at least 3 months of optimal medical therapy. Benefit is greatest in patients with non-ischemic cardiomyopathy, women, and those with minimal myocardial scarring, while response is limited in patients with narrow QRS, non-left bundle branch block patterns, extensive scar burden, or uncontrolled atrial fibrillation without effective biventricular pacing. In advanced heart failure with reduced ejection fraction, additional procedures and devices are considered when optimal medical and device therapy fails to adequately control symptoms or improve prognosis. Coronary revascularization is considered in patients with ischemic disease who have significant coronary artery obstruction, viable heart muscle, and ongoing angina or heart failure symptoms, with surgical bypass favored in extensive disease to improve symptoms and survival. Mechanical circulatory support with a left ventricular assist device is used in patients with refractory severe symptoms, very low pumping function, frequent hospitalizations, or dependence on intravenous medications, either as a bridge to heart transplantation or as long-term destination therapy. Heart transplantation is reserved for carefully selected patients with end-stage disease, persistent severe symptoms despite maximal therapy, poor exercise capacity, and no major contraindications, and offers the best long-term survival and quality of life in eligible individuals. Lifestyle modifications in heart failure include sodium and fluid restriction, weight monitoring, and regular exercise. Smoking cessation and alcohol moderation are crucial. These changes reduce fluid retention, improve functional capacity, and prevent disease progression, complementing medical therapy for optimal management. For more educational content, like, share, and subscribe to Quick IM with Dr. Aid. Your support helps us create even more valuable content for you.